Just to let you know, I need to leave early today.
Thank you, Adia. All right, welcome everybody. This is the Crisis Response Improvement Strategy Committee meeting number 14. And I am Jamie Strauss-Clark, your facilitator. Nice to see all of you. Before we get started with our meeting agenda, I'm going to do my usual spiel about the Zoom technology and how we use it to make sure that we are able to collaborate as closely as possible in this digital space. So Chloe, if you don't mind advancing one, there we go. So as a reminder, I have two of these slides. This first one is for CRIS Committee members, and then the second slide will be for community members and guests. So just a reminder, I'm going to ask everyone to leave their mics on mute unless they are speaking. Can you bounce the button, please? And CRIS Committee members, if it's available to you, please keep your video cameras on. It just enables us to collaborate better in the digital space. Obviously, the most important time to do that is during our discussion period, which will be later in the meeting. So if you want to turn off your camera until then, that's completely fine. Advance the button, please. We use the raise your hand function to indicate when we want to ask a question or make a comment. So to find that, please click on the reactions button. It pops up a window. If you could click ahead, Chloe. And then you'll see raise your hand right there. And of course, if you have trouble finding that, just wave your hands and I will look out for you and call on you in the order in which I see it. You may also, if you prefer CRIS Committee members to offer your comment or question in the chat, you can do that. Click ahead, please. I will read those questions. And what I'll do is I'll take pauses between questions and read those. I see Representative Dent practicing with the hand raising. Representative Dent, nice to see you. Did you have a question?
Well, I had a comment. Thank you. Thank you for getting to me. So both Senator Warnick and I are here. We're in another meeting. And so I wanted to check in. I want to let you know that we were here. If would it be better for me to come back during the discussion period, I would do that. We're just overbooked for the day, and some days are like that. And Senator Warnick would be glad to come and visit as well. Just we're a little bit at your disposal and your request.
I so appreciate that, Representative Dent. And I know your time is spread very thin, so thank you so much for popping in to let us know you're here. We're aiming for our discussion period starting at about 2:50 p.m. So if you need to be dancing between some meetings today and you think you can make it back, that would be great to have you here for the discussion.
Okay, I'll be back at 2:50. All right.
Okay.
Thank you.
Sounds good. Thanks so much. All right. So CRIS Committee members, yes, again, if you would like to offer your question or comment in the chat, please do click on that chat button, enter it there. This is for CRIS Committee members, of course. I will pause some of the speaking, calling on folks with their hands raised and read the chat periodically. Click ahead, please. If you would like to see as many CRIS Committee members as possible, you can click on that speaker view button, change it to gallery view, and you can see everyone on the screen unless there's a presentation up like now. All right, click ahead, please, Chloe. This next slide is for our members of the public. So a lot of the same requests, members of the public, please do keep your mics on mute. And I'm going to ask you to keep so click ahead, please, Chloe. You'll see that arrow showing you where the mute button is. I'm going to ask you to leave your video cameras off. The exception would be if you signed up to make public comment at the end of the meeting. When I call on you, then it would be great if you could turn your camera on, but otherwise please leave your video camera off for the duration of the meeting. Click ahead, please, Chloe, so that people can see where that video is. That's right there. Please don't use the chat with me. I need to use that chat for just CRIS Committee members who are engaging in the discussion. However, if you are having some kind of Zoom difficulty, you can click on chat and send a message to Brittany Thompson, and she might be able to help you with that. The other thing I will suggest is if you decide during the meeting you'd like to make a public comment, we are reserving the last 10 minutes of the meeting for comment. Please do send a chat to Brittany Thompson if you'd like to make a comment, and she will track your names. I will take as many people as possible. We don't have anyone currently signed up for public comment today, If we get one or two folks who'd like to make a comment, each person can have 2 minutes to make their comment at the end of the meeting. Click ahead, please. All right, same instructions about clicking on speaker view and then changing that to gallery if you want to see all of the CRIS committee members or as many as possible. Click ahead, please. All right, I'm going to pause here and maybe we can take down the presentation momentarily. But I'd like to turn it over to Chief Harding, a CRIS committee member who's going to offer our words of welcome today. Chief Harding.
Thank you, Jamie. I really appreciate this chance to be able to just kind of set the tone for a few minutes. I knew coming into this work and being on this committee that I would be coming from a different perspective maybe than most folks. And I welcomed that opportunity because some things that I have learned over my years that I think are universal are that although we may have different perspectives, see the world through different lenses, almost all of us, I think, do this kind of work because we want to make a difference. We want to contribute something positive. And I've appreciated hearing the different points of view and knowing that that's the intent behind it. So it doesn't matter so much if it challenges me or if I sometimes, I'm put on the defensive. That's okay. It makes me think to hear that and to understand that we're all coming at this work because we want to contribute something important. And I think that's the other thing I try to keep in mind. People want their lives to matter and they want their work to matter. And that work needs to make a positive contribution to the world around us. That's why most of us, I think, get up in the morning. So I take that to heart. And the last thing, especially since I know we're going to be working on some of the tougher issues, the last thing I'm just going to ask everyone to have at the front of your mind is to assume the other person's good intent. I don't know if you've ever had a spouse or a loved one that attributed some bad intent to you. Sometimes I'll go to the store for my wife and bring something home that was a guess on my part and it doesn't go over very well. And it offends me because my intent was to do something good and to do the right thing. Most of us are like that. And if we can just attribute that benefit to other folks, I find that it's very helpful. Your intent is as good as my intent. Maybe the different lenses cause that to be a different kind of perspective. But if I can keep in mind that no one's trying to do harm, everyone here is here because they want to do good, and your intent is good, that helps me grow. So maybe that can guide us a little bit as we work through some of the issues today. And again, thank you very much for taking the time to listen.
Thank you, Chief Harding. Appreciate your words of welcome today. I forgot to introduce our wonderful ASL interpreters today. We have Lori and Jackie joining us. They are pinned currently. So if you need that ASL interpretation, it should be pinned on your screen. You can also, again, switch to gallery view if you don't need that and you'll see everybody. But Lori, Jackie, thank you so much. They will be shifting every 15 minutes as you've seen at past meetings. I also want to acknowledge that this is typically the time in the meeting that we've done the last few months where we've had a guest come and educate us about what's happening with tribal-centric behavioral health. I want to acknowledge that the folks that have taken time to do that, including Vicki Lowe, Catherine Akia, Lucy Mendoza, and the wonderful Volunteers of America folks who actually do the engagement on the Native and Strong Lifeline, are providing their labor and expertise free of charge to the CRIS Committee in doing this. And so I want to acknowledge that, first of all, that is very appreciated and that I certainly don't want to take advantage of that by over asking. So today, what I'd like to do in lieu of that is to just make a personal commitment as your facilitator to continue to educate myself as much as I can on tribal-centric behavioral health, tribal sovereignty, and the commitments of the United States federal government to tribes around healthcare. so that I can, as a facilitator, help keep that front and center in the work that we're doing today. So those are my thoughts on that today. Let's put the slides back up, Chloe, and I will walk you through our objectives for our meeting today and how we're going to be doing it. All right, so objectives today, as ever, we're going to start by grounding ourselves in where we've been, where we are now, and where we're going in this CRIS process. Hopefully, if folks have had an opportunity to look at the newsletter that Chloe sent out last week, we're going to hear some additional updates from Governor's Office and state agencies relevant to CRIS work and give you an opportunity to ask some questions. And then the presentation today is going to focus on outcomes from HCA's update of the crisis response dispatch protocols, including how your feedback and the feedback of subcommittees and the work group that focused on this has been considered and addressed. And then you'll receive also an overview of the crisis response best practices guide. Of course, this is a very dense document and we don't have a lot of time. So this is going to be a high level presentation, but you will be provided with a link to the document if you'd like to do a deeper dive into it. And then we're going to use our discussion period today to revisit that root cause analysis that you worked on at our May meeting and begin discussing some recommendations for addressing system gaps related to crisis stabilization as we would capture those in the root cause analysis. We'll confirm action items and next steps and then hear public comment at the end of the meeting if anyone signs up. That's the slide, please, Chloe. All right, so here's the timing we're aiming for. Right now, we're currently at the welcome introductions and review meeting agenda. Next, we're going to move into our personal story. And then after that, we will have some time for the agency Q&A and also hear a little bit from Megan Celadoni at the Governor's Office about how the recent legislation coming out of the last session is affecting the work behind the scenes. Then at 2:15, we'll hear from HCA, the presentation on the dispatch protocols and best practices guide. We're going for a 10-minute break at 2:40. And when we come back, we'll start our discussion on potential recommendations to address systems gaps for crisis stabilization. We'll aim for action items and next steps at 3:45 and then go into our public comment period at 3:48, adjourning at 4 o'clock. Please advance the slide, Chloe. All right, I'm going to turn it over to Betsy now, who is going to walk us through where we've been, where we are, and where we're going. Betsy?
Hi, Jamie. Thank you. Yes, so here we are in June. We've had an action-packed year so far at the CRIS. And what I wanted to do today is to give you a little bit of a sense of what our decision process looks like with the one-year extension added that was created by House Bill 1134. So with the one-year extension, we now have a committee progress report due in January of 24, January 1st, instead of a final report. And that means that our final report will be due on January 1st of 2025. The extension allows us time to focus on areas of discussion that are much needed, including this conversation today, a deeper dive into crisis stabilization. Rather than having to push everything into the final report this year. As you all know, this year's focus has been on the crisis response services continuum and the resources that we need to expand all of those services and supports. We're moving now into a discussion about synthesizing the conversations we've had and recommendations that have come out of this work and our work group discussions this year. And that will enable us to have a foundation of recommendations for the steering committee to consider in our January of 24 progress report. Next slide, please. The calendar allows us to look at some draft recommendations in September that will feed into the report writing in October. In November, the CRIS will be able to provide some feedback on the written draft report which allows more time for review and feedback on that draft report. And this is per a request that we heard last year for the CRIS to have more time for deliberation on the draft report. And then in December, steering committee approval will be sought for the submission of the draft report in January. And then in 24, we're going to turn our attention to the two remaining areas under House Bill 1477 that remain in terms of areas of focus. We'll look at system goals, metrics, and oversight, as well as our system infrastructure, that being technology, workforce, and cross-system coordination. And that is the plan to date. So I'll hand it back to you, Jamie.
Thanks, Betsy. I just want to add one more update before we move into the body of our agenda today, which is at the suggestion of Dr. Snowden at our steering committee meeting, we want to start taking CRIS committee members' pulse at the end of discussions with the intent of using your feedback to continue to create a space for open, candid, and productive discussion with all of you. So today we're actually going to send out a survey. You're going to be getting that, I think, from Chloe after today's meeting. And this is going just to CRIS committee members, and we're going to encourage each of you to just take, it shouldn't take you very long, 5 minutes or less, to fill out the survey and send it back. It's putting your name on is entirely optional. So if you feel more comfortable providing your feedback anonymously, that is absolutely fine. We'd just really like to hear from you so that we can continue to improve and strengthen our approach, processes, my facilitation, et cetera, so that all of you can contribute to this process. So look out for that. I'll do another reminder at the end of the meeting. I think that concludes our slides. So I'm actually going to turn it over to our wonderful CRIS committee member, Anna Nepomuceno, who's going to introduce our personal story today. Anna?
Hi, I'm Anna Nepomuceno. I am the Director of Public Policy for NAMI Washington and a member of the CRIS Committee and also of the CRIS Lived Experience Subcommittee. It is my pleasure to introduce Marilyn Roberts. She is the Executive Director for NAMI Thurston Mason. Marilyn grew up in Mason County. She is the mother of 2 boys. She worked in healthcare for over 30 years. Marilyn's been involved with NAMI for almost 20 years and has served as a leader among multiple NAMI programs, including Family to Family, Ending the Silence, NAMI Family Support, NAMI Provider Education, and NAMI Smarts. She has been a board member, a secretary, vice president, and president for NAMI Thurston Mason. And Marilyn has been a mentor to me. She took me under her wing when I first started with NAMI, teaching me a lot of things with NAMI. Also, she was a great help with NAMI Smart. So NAMI, as some of you are familiar, NAMI Smarts is our advocacy teaching tool where we teach people how to talk to legislators and engage in advocacy. And Marilyn has been such an amazing leader with teaching people how to advocate in Olympia and how to share their story. And she is just all around a wonderful human being. So Marilyn,
wow,
thank you so much.
Who is that person? Thank you, Anna. That was really kind of you. And I'm so grateful that you're here and you're still here with NAMI. I'm hoping I was able to help your initial pathway a little bit. Hello, everyone. Again, as I was so lovely to be introduced as, my name is Marilyn Roberts. I'm also known as Marilyn Roberts Hardy. That's another thing, one of those later life marriages. It's hard to give up that. I had it for most of my life name. Thank you so much again for letting me come and talk. I spent like weeks trying to rappling around with this, and you're right, Anna's like, I've taught classes how to do this. But again, it's difficult when you're talking about yourself, right? Different set of roles. So thank you for letting me come and talk. I was freaking out because my PowerPoint wouldn't work. And all of a sudden it just magically came on. So I don't know, do I have the ability to share?
Brittany or Clay, can you make that?
Yeah.
Oh, thanks.
Oh, I can. Yay. And I can see it. I think it's in like publisher mode, but at this point I am like, can you see that?
It looks great, Marilyn.
Okay, I'm happy. You know, I'm actually at my new desk in Mason County. I'm super excited to say that we just opened our central office for Mason County, one of those rural communities we're all trying to get out information and advocacy. So anyway, thank you again for letting me come. I spent a lot of time talking and thinking about this, running it by my husband, as I do most things. So in context to what you all are all here for, I see lots of friendly faces. I know that's really cool. Here's my life in a nutshell. Who am I going to call? Divert to what? And when will I or my loved one get the help that they need? And like I said, I spent a lot of time pondering this, and someone's going to have to coach me up to stop talking at some point. But I have an adult son who lives with a major mental illness. He has bipolar disorder. He is now 37. Not that my son was the first person in my life that I advocated for many years. And my father also was dual diagnosis, had a lifetime of understanding around that. But when your kid ends up in a psychiatric unit when he's 2 weeks after his 18th birthday, your world changes. Your world changes immensely. So starting at that point, which is why I started here, who are you going to call? In 2004, I got to call 911. We all have stories about that, right? I, at some point, lost track of how many times I called 911. Unfortunately, my son's first interaction in his psychosis was with Thurston County Sheriff's Department. Unfortunately, that was not his last interaction with Thurston County, along with Lacey and Olympia and Tumwater and Tenino. Yeah, so there's a lot of areas that happened, but my calls were always to 911. And I can tell you that was a mixed reaction. As we all know, it is not who I wanted to call. They didn't understand the role of a family member. That being said, I don't need to say how excited I am about the 988 system. We spent a lot of time educating on 988 and getting the word out because it's been long in coming. And I'm so grateful that it's there. I haven't actually asked anybody to call 911 since it started. So I'm crossing my fingers on that one. But I will say a couple of things in terms of what calling 911 puts caregivers at complete odds with the world. It's not what we need. It's not what our loved ones need. And again, I don't need to tell you that. I'm super thrilled with 988 and I'm super happy I haven't had to call it. That's my 988 discussion. I just like to show pictures. My son is charismatic. He's funny. He's an amazing artist. He loves his nephews and his niece. We spent a lot of time together as a family. And I think that's the piece that people forget about. This person is a really integral part of their family, their community, their school, whatever, their church, whatever is happening in your community, they're a part of that. And that's really, really important. In this picture also is my older son. Sometimes caregivers have a tendency to forget, oh yeah, I have other people in my life. He has an older brother by 2.5 years who is his best buddy. So that being said, this is the dilemma. Parents trying to get support for this loved one with a very early diagnosis of bipolar disorder. Back in the early 2000s, I will say the systems felt a little softer. I worked in healthcare, so it was easy for him to be swooped up and brought off to an emergency room and evaluated. And again, learning about systems as a caregiver is difficult. I felt like I had an advantage that area. He went for about 5 years, taking care of himself on the right medication. Things were going pretty well, trying to live on his own, as most young people do. Unfortunately, it kind of rebounded back on us about 7 years down the road. The bullet point in the middle of the divert to what is just like this forever issue for my son. My son has been just about in every facility in Western Washington for one point or time or another based on bed availability. Boy, do we talk about that a lot. I watched my son strapped down backwards in an ambulance and delivered to Fairfax. I've seen him strapped down and delivered to multiple telecare facilities. I've seen him, it goes on and on and on. He had a short stay at Western. Those are terrible situations. Terrible for the family to watch, terrible for the person to navigate and understand. And we're kind of in a different family process right now with my stepdaughter, and I'm watching her go through some of these things. And I'm always in the back of my mind, I'm thinking to myself, why does it happen this way? I'm kind of a systems person. Why does this happen? Who's in charge? Why can we make this better? My connection to NAMI. That being said, where the rubber hit the road for our family was back in 2013. My son was arrested in the bus station, downtown Olympia. For those of you that know Olympia, you know where that is. For smoking a cigarette in an area that had recently been deemed non-smoking. And so for someone who is having difficulty with medication and understanding signs, where to go, what to do, and oh yeah, that sign says don't smoke here. Unfortunately, he was arrested by Olympia PD. To my chagrin, I got a phone call that my son had resisted arrest. I asked myself, what does that mean? So I started making some phone calls, found out the situation. I was furious, absolutely furious beyond belief. And he was taken to the Thurston County Jail, where he stayed for 97 days. And that was the beginning of a really long road for him and for me and our family. For those of you that are familiar with the True Blood lawsuit, as it's known, AB versus DSHS, my son was, I was asked if we would be willing, Kevin and I, to join in this class action lawsuit that you know all about. Right at the top of the paragraph in that lawsuit, it says KR with his next friend, Marilyn Roberts, and that's me. So we entered into a really weird period of life. I had never, ever thought that this level of advocacy was ever needed. I couldn't understand why someone walking in a bus station smoking a cigarette would be thrown to the ground and arrested by 3 officers because he wouldn't comply. And as we know, people with serious mental illness, they're not gauging the moment. They're not understanding the social cues and lots of things going on. And so that moved us forward into this. We entered into the lawsuit. Kevin was very fortunate. He, as a class action lawsuit, as you know, he did not have to come and testify. I did that on his behalf. And it was a real learning experience for me. I had never hernseyed, done anything, didn't know this existed. But what I really felt was a strong, I strongly felt compelled to do it on behalf of not only my son, but like hundreds of thousands of people across not only our state, but other states. And so I had the opportunity almost 10 years later, last Monday, I think it was, Kim. We were sitting in the federal courtroom up in Seattle, hearing the same things over and over again. It was interesting, we'll put it that way. What that did for my son, though, was that he was extremely traumatized. He spent 97 days in the jail and was transferred to Western. And we as a family at that point kind of came to a plan that with Kevin on board, we don't want to do that again. We don't want to have anything to do with that situation again. Although following through with the lawsuit was a big piece for me as his advocate, which is why I have been following it for almost 10 years, because I want that impact on the rest of the world to be felt. Again, a couple of points here, back to my, where do you go? It's forever a dilemma to me when I look at, and I live in Olympia, it's Thurston County. I know the systems that are here. And for as long as I can remember, it's their job. It's their, this other agency, this person, that doctor, this, it's such a bizarre system. Again, coming from inpatient hospital as an employee, there was always systems for things. You have a heart attack, you go here. You have diabetes, you go here. If you're having a stroke, you go here. I just found it interesting from day one that we really didn't have this great protocol for when people came in with mental illness. And that's always been a personal piece for me to help connect people, families, systems to create a better pathway, and kind of in comes NAMI. One of the great days for me was early in my son's illness when somebody introduced me to NAMI. And I was like, wow. And I just told the story in a meeting earlier today. Understanding from a group of people that with that lived experience is really amazing, because I felt at that point, I found my village. I found people with the same language. I found people with the same ideas, the same, struggles, everything that I went through as a family member. Those people were there for me. So NAMI was a big deal for me. I went to their sport groups. I went to their classes. I immersed myself in all things NAMI. And one of the really great things that changed for me with NAMI, it was my language. And language is really important. I don't need to tell you all that. How I talk to people is completely different. Not that I didn't learn great tools working in healthcare for years, but the level of understanding that I have now as a family member and within the NAMI system is completely different. I'd like to say, anyway, I'll jump on. I have to kind of watch my time too, because I'll just keep rattling off. But again, family members, loved ones caught in the system is a huge dilemma. There's not a day that goes by in my work life that I don't get a phone call that says, I don't understand this process. What do you mean? Diverted to where? What do you mean? What's ITA? What did they say? I mean, the language of this entire system is so foreign to the average person. Again, another thing I really appreciate about NAMI and all of their many tools that they give family members to help understand these systems and to advocate for their loved ones to help create change. That's what it's all about, right? Watching NAMI for 20 years, they've been on the cutting edge of this for a really long time. I remember hearing about a 988 system so long ago that I can't even remember where I heard it. And what does that mean? Crisis stabilization. This is fabulous. Why don't we have it? Why don't we have specialized teams of people in our community? Yeah, why don't we have it? NAMI's constantly advocating for change in any way that increases the ability of people to get services, providers, a place to live. Again, I said that's kind of something that's come back into our lives the last 6 months. I have a stepdaughter who suffers from mental illness and also has a substance use disorder. And being displaced is one of the most difficult things a family member can deal with. And again, moving forward, we figured this out over many, many years with my son, but there were systems in place at the time, as we know, pre-COVID, where things were a little more workable. We were able to establish a place for my son to live where it is quiet. He doesn't have sirens and lots of people bothering him. And that was one of the big keys for him to be able to find a place without trauma. Unfortunately, in about a 10-year period and all the hospitalizations, the police involvement, court hearings, and all that kind of stuff basically forced my son into, I don't want to be in the world. I want to be away from everybody and everything. And so he's actually been on his own in an undisclosed place away from people for about 4 years. He lives on a little mini farm that we started specifically for him. And he loves it. He has not been had one issue since he moved there. He takes care of himself, loves the environment, and doesn't have to deal with a lot of things. He has the great luxury, I will say, of being on the PAC team here in Thurston County. But even through the last few years, they've been able to back off his treatment. They see him once a week maybe and talk to him, and because his recovery is going well. The trauma that he went through for over 10 years is slowly starting to peel away. He needs less medication. He needs more interaction with particularly animals. He's an animal lover. He has cats and chickens and things like that. So that has been part of his recovery story, is being away from the area that was most triggering for him. And we're really happy about that. Now, moving forward again, back to my stepdaughter, we're still dealing with, where do you live? Where do you move in Olympia in today's post-COVID housing nightmare? Which is why this third bullet, when will I get the help I need? And again, I hope someone's keeping time to let me know. I have like a minute left. Such difficulty, such struggle for family members and for people struggling with their own mental illness. Many things have brought us to a point where just lately. Systems have been so uncommunicative with each other. I watched my stepdaughter go through 4 facilities over about an 8-month period, including 2 different regular hospitals because they couldn't figure out places to move her. And now she's in this trauma phase where she doesn't want to get support from people because it's too hard to go back into a hospital and have practitioners come and go. And then again, you have the housing dilemma because she's not stable enough to be around people in her mind. And so we're again working with her on some housing options, actually coming to stay back with her family for a short period of time or as long as she can tolerate it, and looking again at getting her set up back in the system. So it's just this ongoing dilemma. And just again, to kind of end this, and it's so hard today. Nowadays, we don't ever have stories of success and like, this is a great thing. Just wanted to show some pictures where my son lives, his cat, hanging out with his family. He's an amazing artist. I finally got him talked into giving away some of his paintings, maybe putting them up for auction. So that we know that these people are unique individuals that live in our community and we want to honor that. He just had his 27th birthday. That's the picture in the middle with lots of family, nieces, nephews, that kind of thing. So that being said, I kind of want to, again, stop and just say, NAMI has taught me many things. Number one, you never give up. There's always people out there to support you, people with lived experience, living your life in your shoes. And the support that we all need. So like I said, I teach lots of NAMI programs. I help family members to navigate this weird system we've created. And that's what I'm gonna be doing for a really long time. So again, being part of NAMI Thurston Mason, we have 2 offices, one in Lacey and one in Shelton, hoping to bring a little bit of NAMI to this part of the world. So thank you for your time. Appreciate everything that you do. Shout out for Kim and Eliza and the rest of the people I know on here. Thank you.
Thanks, Marilyn.
You bet.
I met you, Anna and Deanna, last year when you basically trained us, the Lived Experience Subcommittee, on how to present our stories, and now I'm hearing yours. And as you said, it's different side of the table, and yeah, it requires deep vulnerability, and I am so grateful for yours today.
You're welcome.
What I heard, and it's the first time I'm hearing your story, is that you worked in healthcare and were able to get help for your son. And despite that, it was a struggle. So I can just imagine what must it be for people who do not have, that access. Yeah. And I think what you emphasize is how behavioral health journey is, there are ups and downs in this journey. That's what you basically laid out for us. And I was just imagining the trauma of you seeing your child being strapped to a gurney and taken away. To me, it emphasized the need to have crisis care, but also ongoing long-term care. From your story, you touched upon law enforcement and how it intersects with behavioral health and how we need to do so much better in that area. You talked about housing, but what jumped out at me is that we have to have different models for housing. What your son needs is different than living in a big city kind of thing. That's what, it's like, wow, okay, we have to think about that differently. And I really appreciated your emphasizing your son's humanity, that he's part of a family, a part of a community, that he loves the people in his life, despite and through all his own struggles. I mean, your whole presentation just captured the 3 buckets of SAMHSA: someone to call, somewhere to go, and someone to come. And in this case, the system failed you and your family. And I'm really sorry. And that's why we're here, to see if we can do better for other families. I'm really grateful that you found NAMI and how you use your own lived experience to basically fuel helping and supporting others. And I'm grateful that you shared your son's artwork. It's very beautiful. So thank you for being here today. I really appreciate it. Thank you. And thank you from all of us.
You bet. Thank you so much.
And happy Pride, everyone.
I love your hat.
Your hat is fabulous, Bipasha.
I had to do that. Thank you.
Marilyn, I'm just going to add on my appreciation, and as a fellow mother, particularly appreciated the photos you shared of your son in his happy moments and his creative moments and his peaceful moments on his farm. So thank you for that. And a big thank you to you and your son and your stepdaughter for the bravery and letting us be part of and hear the story today. It does really mean a lot, and it's actually a really important connection to the work that we're going to be doing as a group today on crisis stabilization. So
Great.
thank you so much. And now we're going to move into agency Q&A. So I'm just going to give you a brief overview of how we're going to set this up. You all should have received that newsletter from Chloe last week that provides updates on all the things that have been happening at HCA, the governor's office, and at DOH since we were all together in May. Megan is going to get it started. Megan with the governor's office is going to get it started and talk a little bit about the legislation coming out of the last session and how that affects the work that we're all doing. And she'll also ask Carrie Waterland with HCA and Michelle Roberts with DOH to jump in and add any additional details there. Then Carrie's going to update us on HCA's process and progress in filling our vacant CRIS seats. So we'll hear from her on that. Michael Anderson-Nathy is who's facilitating the crisis response and first responder collaboration work group, is going to provide us with a process update where they are in that process and what to expect coming up. And then we'll have time for Q&A for everyone who is speaking today. So with that, I'm going to turn it over to Megan.
Good afternoon, everyone. If I can go ahead and share my screen, Chloe, that would be great. Let me know when I can. Let's see here if this is going to work.
You should be good to go.
Okay, thank you so much. All right, Jamie, can you just give me a thumbs up if you're seeing the slides versus my calendar?
I am seeing the slides. If you want to click on the presentation button, then we can see the full slide. But if not, we can see it pretty well. So don't worry if you can't.
Okay, let's see here.
Lower right hand side.
Yeah, it's
you know what, don't worry about it. We can see it. We can read it.
Oh, there we go.
Not a problem.
Okay. All right. So I am here to talk to you a little bit about our cross-agency project that we have going on with DOH and Healthcare Authority, and to talk a little bit about how 1134 and 5120 is impacting the work that we're planning for now. I did a little bit of this conversation at the steering committee meeting and at the lived experience committee meeting. And so I know that there's several venues where we repeat similar information. And so thanks for hanging in there if you've heard this before. I've changed a few things up. So hopefully some of it will be new. Just a reminder about my position. I still get a lot of questions about why I'm here and what I do. And how Amber and I work together, and that's totally fine and normal. And I thought I would just comment on it today. So my position was specifically created out of 1477 and was just extended in 1134. And the purpose of the work that I do is to oversee our statewide implementation of 988 specifically. So 988 is obviously building out additional infrastructure for behavioral health crisis services in Washington. Amber Leaders is our behavioral health policy advisor for the governor's office. So she does a wider breadth of policy work on the advisor standpoint. I'm really focused on the project lens of how do we get from here to done with this work in our state. And so I work a lot with Healthcare Authority and Department of Health. We've together created a cross-agency project structure. So just like any other projects, it includes having executive sponsors, project teams, reporting guidelines. We have all of that set up to support our work. I'm also your governor representative on this committee, the CRIS Committee. Amber is still the governor representative on the steering committee. And I work with a lot of stakeholders, and I'm also on the advisory committee for the 911 team. So I'm a voting member there, so I stay in close contact with our 911 state coordinator, Adam Wasserman. He's probably on this call today, and try to stay in touch with their work as well. So just to talk a little bit about that agency project, what we do, as I mentioned in my last slide, we developed an organizational structure to support our work cross-agency. Cross-agency project work can be challenging because we have different agency cultures that exist, different books of businesses, different stakeholders, different ways of working. And so we've really worked hard to figure out what's our shared work together and how do we want to move it forward. We have great teams, we have great intent and a lot of coordination and cooperation, which has helped us a great deal. We have hired a lot of staff, project managers, subject matter experts to support the work. With our upcoming budget enhancements related to the technology solution, we have more staff and contractors coming on board to help us. So there's a lot of onboarding and catching people up to where we go. We'll be developing a governance team to support that IT tech work. We have several project teams. We have executive teams that exist both at the agency and the cross-agency level. We have several subcommittees that convene as well to support the work. Right now, we're talking a lot about how we integrate the work of 1134 and 5120 into our project scope. We're also looking at the deliverables that each agency is responsible for to this team, the CRIS, and adjusting those deadlines to support the CRIS extension. We are looking into the new subcommittee work around geolocation to make some recommendations to support how we move that subcommittee forward. And our state is also as well, spearheaded a 988 affinity group across the nation. So just a couple of talking points on that, because I'm not sure how much this has been discussed, but it's pretty exciting. Our state formed that affinity group. It's been convening since March of this year. 44 states, DC, and 2 territories attend those meetings. They're led right now in large part by Healthcare Authority, but states take on leadership roles with that as the agenda directs topics and as they volunteer to support topics. So things that we've been talking about related to 988 would be things like risks and barriers, advice from state to state, how different pieces of 988 are funded, and how funding works locally and regionally for them as well. We've talked about state plan amendments and Medicaid. We've talked about, and will talk about a lot more, the vibrant unified platform and what states are doing with that, air traffic control model, closed loop referrals, et cetera. And so this is really exciting to support our work moving forward for Washington. And also we've been able to help some other states understand how we've gotten our legs under us here in Washington. So back to 1134 and 5120, just a couple of notes, thinking back to 2021 when we passed 1477 and looking at our broad brush vision of someone to call, someone to respond, and a place to go for adults and a safe place to be for youth. 1477, it did a lot of things, and I'm not suggesting that all of our funding was directed to supporting a place to call, but we really had to focus on that as a state first. How do we figure out and how do we make Washington work with the 988 number? And so that funding really supported the infrastructure there to help DOH get under contract with our NSPLs. When we think about 1134 that just passed this year, again, a lot of funding went to several different things, but a big focus of that bill and something exciting that came out of it was enhancing our capability to respond. And so as I talk through the next couple of slides, I think that's really a key take home is how do we expand our infrastructure to respond to someone that's in crisis? And so these, let me see if I can zoom out just a little bit or zoom in. I can't tell how this is showing up on your screen. So just take yourself off mute if you can't see it, and I'll scroll down as I talk through the slide. But this work on this slide is really has HCA earmarked as the accountable party. It doesn't mean that Healthcare Authority only is doing the work. It means that Healthcare Authority is responsible for the business and the reporting. And so in terms of mobile crisis response, 1134 helped us to expand current mobile rapid response teams. And those are the teams that are currently funded through Healthcare Authority to BHASOs. So we got expansion there. And we also developed the community-based mobile response teams. And so those are new community teams that will be created according to some new program standards. And so Healthcare Authority is responsible for creating those standards. And they're also going to include some rural standards for what those adjustments would look like to support rural areas, because we know that there's differences in our rural and urban areas. So Healthcare Authority is also going to be creating what's called establishment grants. And so this would be if there's teams that have capacity building needs, how can we help those teams get up and running? And they're also responsible for thinking about reimbursement as we think through these new teams. So contracting with actuaries to identify rates for reimbursement and options for enhanced payments where needed. And so they'll be doing an analysis, they'll be looping in OFM and other partners to support that work. Also, a priority is how do we maximize Medicaid match where we can? And so there's some requirements there for report out on Medicaid match. And Healthcare Authority will be doing basically a pay for performance program where if you are a program that meets the metrics in the bill over time, you may be eligible for enhanced payments. So Healthcare Authority has a lot of reporting to do. They'll also be working really closely with BHASOs, Behavioral Health Institute, the Washington Council, and the position that I'm in to support the beginning of the regional collaboratives. And the purpose of the regional collaboratives is to begin by doing some assessment of what's available on a workforce and a training level regionally, so that we can see where there's gaps and needs, and also pull from other regions that may have already developed certain ways of reaching the workforce and have trainings available to support those other regions where needed. So there'll be regional meetings, and then also an annual forum where we'll be able to share what is going on regionally. We still have a lot of work to do around the technology solution. And also we have some additional best practices that we'll be developing for high-risk populations, such as veterans, disabled, LGBTQ+, individuals, people of color, youth, folks from the agricultural community, and our American Indians and Alaska Natives. DOH has a lot of work too. They've got some extensions going on related to their hub rules and their designation process. And so rules will be pushed out to January of 2025 with designation coming in 2026. They are going to be doing some outpatient 988 outreach and education, for folks coming out of outpatient facilities, and incorporating some of that education into discharge information that'll become available. They'll also be doing a 988 statewide media campaign that includes social media components. They have some training requirements related to minimum training standards and agricultural trainings for what will become the contact center hubs. They will continue enhancing their NSPL funding, doing data monitoring and reporting. So that would be providing 988 services and reporting out on that, what services were provided when and how many. They'll be collecting and reporting data, and they'll be working more on the Spanish interpreters and staff, like how do we better serve Spanish-speaking people in Washington. We have some seed funding going on right now for co-location programs for the NSPLs who are wishing to follow through with that. A big piece of work for DOH is the data sharing agreements, and data sharing agreements will be required between DOH, Healthcare Authority, NSPLs, BHASOs, and reports and client level data should become available. They'll be funding the platform in the next year and continuing to work on the protocols between 911 and 988. All right, and then lastly, getting to Senate Bill 5120, and again, thinking about that continuum there. 5120 really focuses us in on a place to go for adults. So important to note, it's not a place to be for youth. This is a focus on adults. And so 5120 establishes a new facility type, which many of us know is the 23-hour crisis relief center. So it provides a place to go. It's an alternative to the emergency room, which is preferable, can accept walk-ins and drop-offs from first responders, DCRs, mobile crisis response teams, and referrals through the 988 system. This is a 24-hour-a-day, 7-day-a-week facility with no medical clearance required. We're looking for a 90% acceptance rate. And of course, these facilities can transfer when medically appropriate to an ER. These facilities will have the ability to dispense medications, and Department of Health will be completing the licensure and certification process by January of 2024. Also, 5120 converted crisis triage facility language to crisis stabilization units. We had some duplication of language there in the RCW that was corrected, and ensuring center services are eligible for Medicaid to the degree possible. And of course, there's requirements in there for tracking and analyzing data from facilities. Just a couple of points in terms of what we're focused on now. You know, we had legislative session that wrapped up in May, and now we've been in the period between passing a budget, planning for budgets, and then budgets and funding become available to agencies in July. So there's a lot of work that goes on there between our agencies and OFM to finalize the fine details of that process. And so agencies that have new positions that'll be able to come on board, such as Healthcare Authority here, are planning for position descriptions and getting ready to post hiring information and recruitments. We held a 2-day in-person planning meeting in June. That was 27 people across both agencies, Healthcare Authority and Department of Health, the purpose of which was looking at assimilating the new work that we have into our current scope and thinking through from a priority standpoint what we need to do. We are beginning to work with the Chief Information Office for project oversight related to the technology work. We also have our policy statement work groups to be convened soon. So those would be, or those groups would be related to the work that was outlined in the policy statement that was released. And we're soon going to begin regional collaborative work. And so the agencies are talking about that and thinking through a path forward. So with that, I'll go ahead and stop sharing and turn it back over to Jamie.
Okay. Rep Orwell, I'll call on you in just a second. I'm going to check with Michelle and Carrie to see if they have anything to add to that, and then we can go into Q&A. Michelle or Carrie, anything to add to Megan's presentation?
I do not. I think Megan had a pretty comprehensive overview for what's in the DOH portion.
Oh, I saw that too. Thank you. Carrie, anything for you to add?
So, hi, you can't see me. I'm in a room. And so you're getting a look at an HCA room right now. No, I think, Megan, you did a great job.
All right. Carrie, I'll come back to you in just a sec about the process for filling the CRIS vacancies. I want to check in with Representative Orwell, who raised her hand there. Representative Orwell.
Thank you. And thank you, Megan. That was a great overview of some pretty hardy legislation. I just was going to say, from kind of the big picture on 1134, kind of the legislative intent, and a lot of it came from this group and from the lived experience group, was how do we have a clinical response to that small percent of calls that need a clinical response? And so again, you know, trying to make our system more robust and be able to respond more quickly, make sure it's people with lived experience on the teams and potential partnerships with EMS and fire. So again, I want to say thank you. And again, we're really hoping that the regions will come together to kind of create things that make sense in their area of the state. So thanks.
Thank you, Representative Orwell. Bipasha.
I had a couple questions. Megan, the affinity group, who attends those meetings? And are there people with lived experience in those meetings? In addition to, I know a lot of staff who come to our subcommittee meetings have shared their own lived experience, and I'm very grateful that they both do the work and have lived experience, which informs their work. But Is there a specific focus on including lived experience? And is it a kind of meeting that CRIS members can join if they should have the time or want to?
Thanks, Bipasha. So this meeting is attended by other states and territories that are also implementing 988. And so I believe it's 44 other states, District of Columbia, and 2 territories that attend. And so if we need more information on that and who attends, I would have to kick it over to healthcare authorities. So maybe that's something we can get back to you on.
Okay, thank you. And just for the record, I want to say, once again, if we could have CRIS meetings in a hybrid way, in person, and for people who want to be on Zoom. Just want to say that for the record.
I'm sitting in a room by myself, Bipasha, so I'll say that on the record.
That's a good start, though. We're off to a good.
We made one live, and I'm by myself. So we will make this live and in person. May not always be a healthcare authority, might be a roving thing, but did want to point out for the record that this is an opportunity for folks today. And I'm hopeful that someone next time will take advantage of it. Let's see. I am going to share, I think, a little bit, right? Because we do have 3 positions that are open. And again, I apologize because you're not seeing my face, but you are seeing a door at Healthcare Authority. So everyone, I wanted to let you know, we did a little bit of talking last time at our steering committee meeting, if folks were there, to hear that we did have a vacancy still for an organization that specializes in facilitating behavioral health services for LGBTQI+ populations. The Healthcare Authority did advertise that at what we have, which is the Saying It Out Loud conference, which is specifically for bringing together LGBTQI+ populations to discuss behavioral health services, the needs, gaps in the services, and really bring folks together for fellowship. So that position was announced, and we do not have any folks who have reached out yet for that opening, but I'm going to make a pitch for that and 2 more in this open meeting today to let folks know we still absolutely need someone to fill the organization that specializes in facilitating behavioral health services for the LGBTQI+ population. We are working and continue to reach out to organizations and providers about this opening. We do now also, as we talked about at the last steering committee meeting, have 2 new vacancies. One is for a member representing a university-based suicide prevention center of excellence. And the Healthcare Authority right now is reaching out to the University of Washington and Washington State University and other universities. If we hear that there are other university-based prevention centers of excellence and university-based suicide prevention centers of excellence. So we will be continuing to reach out for that. And then the last position that we have open that the team is consistently reaching out on and will consistently reach out on is an EMS related emergency medical services related organization for a member who represents an emergency medical services department with a CARES program. So team, if any of those fit you or people that you know, or as I love that Bipasha always is finding out if there is opportunities for us to expand our reach, if you have lived experience and you fit into one of these seats and the way that they're described, we would sure love to talk with you. I know that the team is going to be coming on and you'll have a chance to talk with Matt Gower and a few others today, but we will be taking any questions at the HCA 988 website. And Jamie, I think we can maybe drop that into the chat if it's possible. Thank you so much. Team, if anybody is interested and you want to nominate yourself, or you've got other avenues where we can go and just do some reaching out, we will take any and all of your advice, your suggestions. It's very important to us that we get these 3 seats filled. And I'm just going to say them one more time because you know I love repetition. We are looking for the LGBTQI+ seat that's specifically for an organization that specializes in facilitating behavioral health services. We also are looking for a representative of a university-based suicide prevention center of excellence. And lastly, we are looking for an EMS, that's emergency medical services, seat with a person who represents an emergency medical services department with a CARES program. Maybe I will stop and see if we have any questions.
Thanks, Carrie. And I just put that email address and a reminder again of the vacant seats that we're looking to fill in the chat for everyone. So please do send an email if you think of any ideas. And we'll do Q&A in a moment. I want to turn it over now to Michael Anderson-Nathy, who's going to provide a brief process update on the crisis response and first responder collaboration work group, and then we'll do Q&A. Michael.
Yeah, thank you, Jamie. Good afternoon, everyone. Again, Michael Anderson-Nathy, he, him, his. For this brief update, I'm just going to cover kind of where the group is at and kind of when to expect some of the outcomes from it. So this is a work group that's charged with developing recommendations for the CRIS Steering Committee on ways to ensure an appropriate, effective, equitable, and safe collaboration between the behavioral health response system and first responders. Okay. It has about 22 people that attend this group, excluding the staff that are supporting it. And this includes representatives from first responders and behavioral health crisis systems, from the state, from people from the Lived Experience Committee, CRIS members, as well as subject matter experts, who are all coming together to address this kind of charge for this work group. The process that we developed and are using with this work group is really kind of a 3-step process, right? Where we started with brainstorming barriers, fears, or concerns about first responder and crisis response system collaborations, right? So like what gets in our way of having a safe, effective, appropriate, equitable collaboration. And we started there for 2 primary reasons. One is we wanted to give everyone a chance to name their fears and concerns so that people were not kind of holding them in, all right, or kind of sitting on these things. And 2, to explicitly name them so that we could then develop solutions or ways to address them, right? Like it's very important to be able to name kind of the barriers or challenges so that we can then collectively try to come up with some solutions. Once we did that, we moved to developing recommendations for each of the barriers that we identified, and are really in the process of completing that process now, really kind of mitigation or strategies to address those fears or concerns. After we finish that, our plan is then to map those recommendations onto what we're calling 6 pillars of systems change. So these are kind of areas where we think a comprehensive recommendations need to attend to 6 areas in order for systems change to happen. And a very quick high level, that's like, is there leadership or political will around it? Is there adequate resources for it? Are there policies that kind of outline the expectations? Are there then procedures or protocols or workflows to help people implement those policies? Is there sufficient training so people are skilled to do it, to deliver these things? And then what's our monitoring and accountability plan, right? So we've brainstormed barriers, challenges, and fears. We're coming up with recommendations and strategies, and then we're going to map them on those 6 areas to make sure that we have a comprehensive response, right, for this charge that we're doing. We started initially with 3 meetings, but we're adding some more. And so we're probably about halfway through. We have 2 more meetings scheduled. And we are also in the process of collecting some feedback from the Lived Experience Subcommittee via survey. And so that's also in process. So that's kind of where we're at. We're hoping to finish this by the end of the month, I believe. So I would assume probably in July for a more thorough update to the full CRIS with what this work group ends up developing. So I think that's, I know, Jamie, we're kind of behind, so I'll leave it at that, unless there's anyone from the committee who wants to chime in about the process or the product so far.
Michael, this is Betsy. I will also add that we are endeavoring to get some feedback from the tribal subcommittee.
Perfect. Thank you, Betsy.
Thank you, Michael. That was very helpful. I'm going to open up to CRIS members for any questions regarding what you heard today from Megan, Carrie, Michael, or what you read in the newsletter. I also received a question from Kashi, who's not able to attend today, but had read the newsletter. So I'll share that momentarily. It's actually more of a comment than a question. And I'll also forward that along to Megan so she can answer it directly. But any questions from CRIS committee members? Okay, I'm going to briefly summarize Kashi's comment here, and then I'll turn back to CRIS committee members to see if you come up with any other questions. She wrote a comment, she read the newsletter, and in particular had a comment regarding the policy statement on the roles of 988 call centers and regional crisis lines. So I'll just briefly summarize this. Healthcare Authority and Department of Health released a policy statement on the roles 988 and regional crisis lines. They support the continued work of regional crisis lines. Agencies will form a work group by July 1st to conduct a comprehensive review of 988 implementation over the next year, with the goal of making recommendations in coordination with tribal partners and stakeholders on the duties and responsibilities of the designated 988 contact hubs, the duties and responsibilities that BHASO regional crisis lines may still need to provide to their region, and any prospective changes to the system. And Kashi's comment here was, as part of this comprehensive review, it seems critical to examine the difference in access to resources between 988 and regional crisis lines. I'm specifically thinking about regional crisis lines being able to identify youth callers and dispatch mobile crisis teams or MRSS teams, whereas 988 may not be able to identify youth. I think we talked a little bit about that at the last meeting. This is a key difference in access to care and access to best practice, which this comprehensive review may inadvertently omit if not intentionally called out. So what I'm taking this to mean, and Megan, I will, and also HCA, so Carrie and Michelle, I will forward this whole comment to you so you can see its full text. But I take this to mean that Kashi is really hoping that that work group that's going to be assembled specifically looks at these differences and in their evaluation. One last call on questions from, thanks, Carrie. One last call on questions from CRIS members. All right. Well, then what I'm going to do now is turn it over to Matt Gower with HCA, who is going to give you a presentation on crisis response dispatch protocols and the best practices guide. And Matt, just to cue you up, if you could either yourself provide the link to the toolkit or point us to it so we can put it in the chat. I just want to make sure people have access to that when you're done with your presentation. And I'll turn it over to you.
Yeah, I don't have a link for the toolkit as we were planning on distributing it after this meeting, just in a mass email for feedback. We don't have it posted on any public websites or anything like that yet.
That's fine, as long as it gets out. Thank you so much.
Yeah, and part of it is we've been trying to get some formatting issues settled and things like that before we send it out. But good afternoon, everyone. My name is Matthew Gower. I'm the Crisis System Team Lead here at the Healthcare Authority. Thank you again for bringing me back to talk with you. What I'm going to cover today is essentially the biggest work product we've had from 1477 to date. It's the Crisis System Toolkit, which was laid out in 1477. It had a requirement that has changed a little bit from the original intent. In 1477, DOH would be announcing the rules and basic structure of the crisis contact hubs at this point, and this best practice manual was supposed to be an implementation and program guide to go along with it. But with the passage of 1134, that's moved the development of the crisis contact hubs a little bit further out. So we've adapted this toolkit to be more of an overall implementation guide for the system as we continue to integrate these crisis contact hubs and other services into our current system. Sorry. Next slide. Good. All right, thank you. So again, just want to kind of give a background on why we're doing this, what's in there, and then I'll show you some of the components of the toolkit. But as I mentioned, House Bill 1477 mandated the creation of this toolkit. It mandated the best practice guide for crisis contact centers, a high-risk guidelines, information sharing protocols, and dispatch protocols. And I'll go over kind of how we modified the approach on all of those, and talk a little bit about the information sharing protocols and next steps on that as we get further into it. But the toolkit overall now is meant to be kind of an implementation manual going forward for implementing SAMHSA's best practices, as well as capturing all of the current practices that already work and how we can build off of those to implement the best practices. Next slide. So the overall system goals for this toolkit, again, are to create kind of standardization. 5120 did change that little kind of regulatory itch of mine of crisis stabilization and crisis triage being functionally the same at the statutory level, and that allowed everybody to call their crisis stabilization or triage whatever they wanted, but it made it very hard if you weren't familiar with the area to understand what you were referring somebody to, what beds were available. So this is just kind of an example of how we're trying to create standardization. We don't want to override what our regions do and how they've made their systems work, but we do want to make things recognizable in case phone calls go out of region or somebody's new to the region, so we can quickly identify and help people find the resources they need. We're also hoping that this toolkit will improve coordination, not just within our own crisis system, but with all of our partners. So with our 911 or first responders, but also schools, community partnerships with shelters, food banks, that type of thing, and start really explaining our system to them and how they can better utilize our resources and how we can better work with them. Most importantly, too, for equity is changing decision making. So we really put in a lot of emphasis in here about how to reevaluate situations, how to think about different resources as they come online, are more available, and utilizing them first. The idea being that we don't wait till somebody's at a higher acuity to get help, but we can provide them help earlier and with a more voluntary, a less restrictive option. And by doing that, we improve the equity. Going back to the lived experience comments earlier of, that trauma period of going to a hospital, not getting all the support you need, that does make people not want to reach out, and that does make the chance for the next crisis more acute, when we want to limit that by getting them the resources they need now. And then another big piece is teaching our system partners. A lot of what we've heard in doing this work and the research for this toolkit is a lot of confusion on what the roles are. A lot of regions do things slightly differently. So police, when they're talking to each other, often hear how somebody else tries it and they try to do it in their region. And really just putting it out there on how our system works, what resources we have, and how to access it. Trying to get away from the scenarios where we run into frequently, where we hear from our EMS or law enforcement that they took somebody to a hospital and then a few hours later they see them out on the streets because, well, the law enforcement officer thought they detained them, the hospital found they wouldn't meet criteria and released them. So trying to figure out, through this toolkit, how we can mitigate those situations, better improve communication, coordination, and get better outcomes in our crisis system. Next slide. So the components of this toolkit that we've adapted from the original just basic requirements is we did put in an overview of this crisis redesign project, where we're at, the different milestones that are ahead, to kind of give all of our system partners and ourselves a good view of what we're doing and how to get there. We also included a systems level best practices. So these are things that can be adopted across the system, whether it's a call center, a mobile crisis team, somebody referring to the system, all of that, just what are some ways that we can improve our system there. And then we created the Crisis Contact Hub best practice guide. So this is kind of a way for our NSPLs and RCLs to start seeing the work they do in each other, as well as providing that standardization across systems to improve coordination. We also built off of our mobile crisis outreach, mobile crisis response program guide we built last fall and added more best practices, met with the workers and added more tools and made that guide more robust. And then we created the standardized dispatch protocols and the high-risk guidelines, which I'll go into far more detail here in just a minute. Next slide. So the development of these processes was pretty straightforward. Where we were not the experts, so where we're not actually doing the work, mobile crisis, call centers, we didn't write it. We brought them in, we had them tell us what they did. They shared policies and procedures, they shared information on how they do it. We captured that because we're not the experts there. We didn't want to assume everybody on my team has experience in the field, but I haven't done a service in 5 years. So I'm probably not up to date on everything. And we wrote it with them. The dispatch protocols were a little bit different. This one is a bit more of a important document. It's really the first attempt to start really pushing the onus away from active rescue to behavioral health response whenever safe to do so. So the dispatch protocols were originally created through the mobile crisis and call center best practice work groups, as well as looking at the state of Georgia, LA County, and a few other states, I think Virginia and Michigan, and their dispatch protocols. We built it off of those templates and with the information that our crisis workers would want. But then we took it to the lived experience subcommittee for its first real test pilot and got fantastic feedback. Two of the areas that were really pointed out that were blind spots to us was we didn't feature equity as forward as we should have. And all the work we were thinking we were moving away from active rescue and moving more to behavioral health response that's addressing equity, but the language definitely was not clear in there. So that's one area that we made a major improvement right away. Another area was we didn't focus on our system partners and how we could utilize them still in these situations. So we put that in there better to, again, put the emphasis that even if an active rescue is needed, behavioral health should be the follow-up or the handoff point. And then once we got that feedback, we took it to a CRIS work group. Lots of you on here were part of this work group and are also part of the first responder work group that's going on in parallel. But we kind of got a lot of really good feedback from that work group on parts that were missing, clarity, and again, making sure we're focusing equity. So the dispatch protocols is kind of more of a joint effort from CRIS members and us to develop kind of the template moving forward, I guess. 1134 will require our regions to create dispatch protocols for them, but we're hoping that this template can start changing the thinking as we're developing those and serve as a initial idea to build off of. Taking in all the values from the CRIS committee and going back to our regions and saying, how can we implement this and what would that look like in your region with your resources and your geography. The high-risk guidelines were probably the harder one to build out of all of this. We took an approach that we really want to just show where there's risk and not where there's no risk. It's a very heavily researched document where we really try to dive down into what different populations are at high risk of overdose, suicide, harm from our crisis system, and what are some risk factors to be aware of in these situations, of what are some protective factors for those populations. Our original charge was to look at it from the lens of geographic location, socioeconomic status, race, ethnicity, age, and gender, and sexual orientation. But we added a little bit more, including veteran status, disabilities, to try to cover some of the accessibility gaps in those areas as well. The current process for this is we ran it through an internal and original external review process. Now we are in the tier 3, and as soon as we can get some of the formatting issues done in the final template, we will be sending it out for your guys' review with the goal of having this published by July 1. Next slide. And then, so before I show kind of what the document is and all that, just want to highlight some of the areas that we know will adapt as we go forward. So the first piece that's already happening is we're adapting it based on feedback. Lived experience subcommittee has been huge in the creation of the dispatch protocols because that's kind of setting the needle of where do we want behavioral health interventions to live and where do we need the active rescue components from our system partners. And then, of course, as we start going into the regional work, we'll be adjusting to capture in more regional nuance and how the systems work there. Training will also drive what changes in this toolkit as we go out and we say, okay, we're providing way too much information on this, but we need to do more on this. And then we will also add more components as we go forward. This includes crisis system, crisis facilities, which we held off in this round because we wanted 5120 to mature and be implemented before we added that into an official guide. And then the creation of information sharing protocols, which going back to the original intent we would have been creating information sharing protocols for a known entity of the crisis contact hubs. Now we don't have the full structure on what everything will be. So we're kind of delaying the creation of that, but we will also be looking at those co-location pilots and these regional coordination meetings to help us develop better ways of developing information sharing protocols and the best practices for that. And next slide.
Matt, I'm so sorry to interrupt. Just for the benefit of Jackie, who's doing the interpreting, and I realize we're at the end of the slides here, but if you don't mind just slowing down just a little bit so she can catch all the words.
Absolutely. Sorry about that, Jackie.
No. I know you were trying to cram a lot of information into a short amount of time, so I really appreciate your speed here. But so CRIS committee members, any questions for Matt? Matt, I take that to mean that you had a very informative and thorough proposal. I see a note here from Bipasha. Big shout out to Matt and his team for showing up every time at our lived experience subcommittee meetings and sharing what they're doing directly with the community. So they are more empowered to reach out to HCA directly to get questions answered and being guided to different and better resources and using the input they hear to mold the system to serve people better. Not just that, they are generous with their vulnerability and sharing their own lived experience and how that fuels what they do as professionals. I am grateful for that because it lowers the walls between those who need help and those who provide help, which is honestly a false divide. So thank you, Bipasha. And Matt, any of your colleagues who are not here today, if you don't mind sharing that message with them as well. I think all the effort that you make with the lived experience subcommittee and with this committee is very appreciated.
Thank you, Pasha. And it's been, Pasha and Puck, thank you again for all the work you guys do to help us coordinate with you and develop the lived experience subcommittee program and itinerary. You guys have been fantastic to work with. Thank you.
So CRIS committee members, any other questions or comments? So Matt, as I understand it, you'll be emailing out once the formatting has been finalized, you'll be emailing out this toolkit so that folks that want to do a deeper dive into it can take a look.
Yep, absolutely.
Okay.
That should be going out by end of day tomorrow at the latest.
Excellent. Well, everybody, we are having a rare moment here at CRIS, which is we're 10 minutes ahead of schedule instead of 10 minutes behind. So what that means is we can take our break now, and that'll also buy us a little bit of extra time for our discussion, which I always appreciate. So let's take a 10-minute break. It's 2:28. I'll just round up here. If everyone could be back here and on camera at 2:40 p.m., we will dive right into our discussion. Matt, thank you again for a great presentation, and I'll see you all in a few minutes. Okay. It's 2:40. I'm going to just keep an eye out and see cameras coming back on. All right. That works, Carrie. I know you're there, even if I can only see your thumbs up. All right. One more sec here for folks to come back on. All right, Chloe, if you're ready, if you could advance the slide, I'll set up the next discussion. All right, welcome back, everyone. So as you saw in the agenda, and we talked about at the beginning of this meeting, we want to go back to that root cause analysis that the CRIS Committee worked on at our May meeting. This is when we focused on the question of even though crisis stabilization services are there to help stabilize people in crisis and get them back to a safe place, not everyone who needs it is able to access that. And we worked on some questions of why is that? What are the root causes? What we want to do today is revisit that, identify the root causes that you all came up with that are actually within the CRIS's purview to influence, and then start the process of brainstorming some ideas for how those systems gaps might be addressed. So that's the goal of today's exercise. And the intent here is to inform both steering committee recommendations for the 2023 report to the legislature and, as I understand it, support HCA's work in doing some strategic planning. And actually, to set that up, I'm going to ask Carrie if she can just share a few words about how the CRIS's input might be used to influence outcomes, and then we'll set up the exercise. Carrie?
Thank you, Jamie. It's so weird seeing just like this box of seats. So I hope that my voice is just coming in from the Ethernet and landing on all of you with some good vibes. Jamie, thank you so much for just giving me a couple minutes to help with the context. I want to harken back to exactly what Matt was just talking about with best practices and kind of pattern plans, and talking about this. Those were brought to CRIS, those were brought to the steering committee, those were brought to the lived experience group. And this is no different, right? I think we know. And again, going back and borrowing from Matt, a great team member's words, we have subject matter expertise in some of this. We are not the experts in all of this. We desperately need your voices, your experience, your expertise, and your hearts to tell us, what are we missing? We're going to really talk through a lot of the things that are going to be future recommendations that will end up in the strategic planning work that the Healthcare Authority will do, that will end up in the annual report to the governor and the legislature. And just know that while it sometimes may seem or feel like this is a large group that does talking, your words are landing. They are being incorporated into, again, the work that Matt just walked us through. They will be incorporated into reports that we send back to the governor and the legislature. And lastly, we only know things from our lens, which is why we really want to be able to continue to come and have conversations with everyone about what are the gaps in our system? What do we think is the best way to not only close those gaps, but to overshoot and produce really, really great quality care that is at the right time, in the right place, with the right services. And for that reason, I just am thankful again, Jamie, that you gave me an opportunity, because I know it feels and can feel sometimes like these are big meetings, and should you raise your hand, and should you speak, and should you share your thoughts? And to you, I say, yes, please. We want to take that feedback. We want to take your voices. We want to honor them and see what we can do in order to move our work forward. So Jamie, I think the big takeaway is we know that folks on this call together will all have the best path that we can move forward. And for that reason, we're listening with open ears and open hearts. And just know, just as Bipasha said, folks have been coming to the lived experience group, and it's led to comfort, reaching out to HCA. I hope that as you see Matt more, and Wyatt more, and me more, and others on the team more, you know that we are here for you, for your feedback, and to listen to your words. So Jamie, thank you. And that is what we will be here today to do. And we look forward to being able to translate your words into our future work.
Thanks, Carrie. I appreciate that. So with that, I'd like to set up the discussion today. You should have received in the email packet from Chloe last week, the root cause analysis. What I did was I took all of that input that we put into that worksheet and I synthesized it into, I think it was 4 pages. And I did kind of a flow chart form because I think that was easier to follow than the fully built out worksheet that we all worked on together. I recognize that many of you, all of you, have really busy schedules and may not have had a chance to do a dive into that root cause analysis before our meeting today. But it's going to be pretty important for everyone to be grounded in what's in there. So what I'm going to try today is something new, which is I'm going to give you 10 minutes to review or re-review that root cause analysis document that we sent out. And I'm going to ask you to consider, as you're reviewing that, the 3 prompt questions that we sent out. So Chloe, if you could expand the slide. Sorry, advance the slide, please. All right, so the 3 questions I want you to consider as you're reviewing that root cause analysis is, first of all, which of these root causes do you think are within the CRIS's scope to address or influence? HMA put in here a reminder of the role of the CRIS Committee, which is to advise the steering committee as it formulates its recommendations to the governor and legislature for an integrated behavioral health crisis response and suicide prevention system. So thinking about our role, which of these root causes that are documented in this flow chart do you think we are in a position to influence? And then I'd like you to also consider what are some ideas or potential best practices that state agency staff could investigate to address a problem that you identified as within CRIS scope. So if you've heard about things that are done in other states, if you've had observations based on your professional experience or personal experience or reading that you'd like HCA and DOH and others to maybe investigate further, those are the kinds of ideas we're looking at here. And then in addition, so along the same lines, what are some potential policy, funding, or legislative solutions to the problems that you identified as within the CRIS scope? So I'm going to ask all of my CRIS members to go back to that email that you received with the agenda. And actually, Brittany, I think is just going to hit send again on that email so that it's top of your email box. So you don't have to dig in again for it. And I'm going to ask you to take the next 10 minutes. Come back on camera. You can turn off your video camera if you like. Take the next 10 minutes to review or re-review that document so that when we come back together, we can be prepared to have a discussion about it. Brittany, were you able to send that out?
Yep, I was just typing in the chat. I just sent it.
Okay, great. So if folks don't have it readily available, it should be at the top of your email box in just a moment. And let's all come back on camera at 2:50, prepared to discuss. Hey, CRIS members, I'm seeing some of you starting to come back on, and invite all of our CRIS members to turn your cameras on. We can start our discussion. I'm just going to give a quick reminder of the questions we want to start answering today. And then I'm going to ask Chloe to take down the slides so I can see all of your wonderful faces. So again, I asked CRIS members to take a look at that root cause analysis and think about which of those root causes they think are within our scope to address or influence. And then start brainstorming some ideas for solutions or best practices that either could be further investigated or might be something we should consider talking about more to adopt or propose as a recommendation rather. So Chloe, if you don't mind taking down those slides, I'm also just going to post this in the chat so everybody remembers what our questions are. And the way I'm thinking we can do this is I'm going to ask CRIS members either raise your hand or put this in the chat. Let me know which root cause you want to focus on, and then what, if any, ideas you have. And then when subsequent CRIS members want to jump in, let me know if you're going to talk about a new root cause or if you want to build on something or respond to something that one of your CRIS colleagues said. So anyone want to kick it off? Well, maybe to see, oh, Dylan, I always can count on Dylan to kick it off. Dylan, what are you thinking about?
Oh, looking at all the various root causes, I think the easiest one is the lack of information for the general public. It's the easiest one for us to address.
And did you have any thoughts or best practices that you've observed elsewhere that you might propose we start thinking about?
You know, I think it's just I guess taking up the mantle and being a good ambassador for the service, the system that we're trying to build here, and you know, talk with your friends and families, and yeah.
So maybe leveraging the networks that we already have that are already in place. Yeah.
And
okay.
You know, at work too. I know for one of the things we're doing is that at my agency we ended up making sure that the materials that were made available by SAMHSA, that they were translated and printed out, so we were able to hand them out to folks as they're coming through, that were incorporated in part of our patient education.
So using every opportunity that we have to communicate with people about these services and the system we're trying to create.
Yeah.
Thanks, Dylan. All right, I think you catalyzed some energy here. So let's go with Representative Dent.
Oh, thank you. So, you know what I see, and I've talked about this for years, is as long as we continue to have this very strong mental health stigma, then I don't think any of the other possibilities. I mean, it affects everything we do. Absolutely affects everything we do. So if you're afraid to go to get help, then, you know, and I went back through there, you're going to end up with a lack of services. Number one, you're not going to know where to go. But number two, if enough people aren't going, we have a lack of services, right? It just kind of, it snowballs itself. And the lack of database. So if you have people reaching out for a database, there's no reason to create a database, right? Which is, and I really believe that the one thing that would do more good, and I want you to know that I'm taking some of this from life experience and having a mentally ill child at home and looking at what he goes through and how hard it is for him, even though he gets a tremendous amount of support from me and his mother. It's, you know, he has a hard time because he knows he's different, okay? And these folks know they're different. And so some of the stigma they put upon themselves, and there needs to be some kind of I believe, a public relations approach to this, that although it's different now than it was when I grew up, it's not enough different in my eyes. We need to help these people understand that, hey, yeah, you might be different, but maybe instead of being different in a bad way, you're different in a good way, you know? So, you know, my son, who, you know, is bipolar, schizophrenic, they've diagnosed him with so many things, I don't even care anymore. But I'll tell you this much, he's very brilliant, okay? And in order, and to build on that brilliance, help them understand that, well, you have some talents that I don't have. and teach these young folks, and also through a PR program, teach them that, yes, you're different, but maybe that difference is a good thing. Maybe you can do something with that to help those of us that don't have that, right? I mean, spending time with my son, I wish I had the memory he has, to remember something that happened 12 or 15 years ago with great detail, escapes me. Okay, it's gone. It's not in my DNA. And but I really believe we need to focus on making it okay that you have these challenges, and making it okay that we'll find the solution. And I don't know that we do enough of that. So that's really kind of where I'm at. Been there for a long time, and I think about, well, how do we do that? That I would be interested in others' ideas on how we could move forward, how we can do that, how we can work to remove that stigma and make it more normal, because there are so many folks that are there, and as long as they have that feeling of inferiority, of being inferior to others, it's going to be very difficult for them to receive treatment as well. So anyway, there you go. I'll finish for now. Thank you. Thank you very much, Jamie.
Thank you, Representative Dennett. And as ever, I appreciate your vulnerability and sharing your own personal experiences here. I think that was a really sort of serendipitous segue from what Dylan had mentioned about the importance of communicating. And I appreciate your suggestion about a PR campaign that's maybe also about maybe strengths-based, like not just focusing on the distress that this causes, but in fact, maybe some of the other ways of looking at mental illness. So thank you for sharing that. Claudia.
Yeah, we just want to echo what has been said so far, but also add that if the stigma is really difficult around mental health, it becomes a lot more pronounced when you look at people of color, because that gets combined with our own cultural beliefs, with what we think is happening with the person. Where do we think that we should be going? How we should be getting the help? And the stigma becomes confused with our own values, with our own way we interpreting what's happening with the family member or whoever is at home. There's so many cultural beliefs, not only especially in a lot of the immigrant communities, who are very different at trying to define as mental health. So I definitely believe that we should be very intentional in creating this subcommittee of people of color, or people of very intentional, not having one representative here, but really intentionally, how are we planning to disseminate all this information in different communities of color? People who are migrating from Central America, people who doesn't even speak Spanish, like how we really kind of make this system accessible to them. So I think that would be a role of this committee, having a subcommittee which is really intentional and focusing in, how we are assessing or getting this information to other communities.
Thank you, Claudia. So if I'm hearing correctly, the suggestion is, and this is building on the theme of communications that Dylan and Representative Dent spoke to, and you're talking specifically about how messages need to be tailored to different cultural communities, using, I think, the same message that Representative Dent mentioned about stigma and removing stigma. And so you're proposing maybe a solution to explore is to have a subcommittee comprised of people of color from different cultural communities who can advise on how the messages are communicated. Did I get that right?
Correct.
Okay.
Mm-hmm.
Wonderful. Thank you for that. Vipasha.
Okay. So I've been harping on this for a while to have a kick-ass database. Washington State needs to really get their websites to be extremely user-friendly and comfortable to use. And this database available to all professionals, but also to the public. I think if we can build a database that has a segment on education, how to prevent stigma, and all the resources that are available. I don't know whether this is already a thing, but if we can have every behavioral health provider, whether it's an agency or an individual, be mandated to be listed on this database in order to practice in the state of Washington. And I mean a database that has resources for people who do not have anything, as well as resources for people who are very wealthy. And the reason I say that is, if you can go to a database and say, oh, this is available, but my insurance doesn't cover it, but these rich people can access it, that's going to show us all the gaps in the system right away, and how resources are not available to everyone in an equitable way. But I think it's an expensive endeavor, but I strongly believe it will change the game if we can mandate all providers to enlist, be clear on what they provide. And then in this database, you can have things in Spanish and different languages, but a really comprehensive database. And I am not the tech person, but I can tell you from the millennials and certainly Gen Z and now Gen Alpha, they're going to be online all the time with ChatGPT and AI. That ship has sailed. So if we don't tap into the internet and make things accessible for these generations, we will have missed a huge opportunity. Okay, that's it.
Thanks, Vipasha. And yes, I have heard your database idea, so I'm glad you echoed that. I do have a few, I want to take Anna. I do have a few chat comments too, so I'm going to take Anna first and then go back here. But Anna, really quickly, I just want to read a chat comment from Dylan because it's in direct response to what Vipasha just shared, which is just raising a challenge. I don't think opposing the idea, but maybe thinking about adding some nuance to this that we might want to consider if we look into this idea of a database, which is that one of the challenges of building databases is that everyone thinks they can make a better database. And then we have one more database that we have to update along with other databases. So I think, Vipasha, I've heard you talking about having some kind of centralized one that providers are required to, I think you just said providers are required to keep their information up to date. So I appreciate Dylan raising that as something we should think about mitigating for. All right, Anna.
So I just wanted to speak more on what Representative Dent brought up regarding stigma and a PR campaign to help reduce that stigma. I wanted to talk specifically about the crisis centers that will be built around the state, especially with the passage of Senate Bill 5120. Anytime you have a proposed facility being built in a community, you get community pushback. And a lot of times this can cause delays in building the facilities. It can get held up in litigation, and it can cause a sense of distress, especially for people living in that community who have behavioral health issues, in themselves, or they have family members that have mental illnesses. I experienced this with the Stanwood facility, which I know is not a crisis facility, but still kind of, there was that pushback from the community, all based on fear and misunderstanding of what it means to be mentally ill. And as far as community members who had mental illnesses, they came to me in private and were very, very, it just drove up the anxiety because of that. And so I think if there was a way to identify the areas where there's proposed facilities or, in the works, and perhaps doing some type of a PR campaign among those communities to educate them about behavioral health and to help alleviate any of their fears and to really dissuade that stigma, I think would be really helpful. That way we can try to avoid or at least mitigate the pushback and mitigate years and years of possible litigation, because we do need these centers to be, we need them now. We don't need them held up in court. So that's just kind of my 2 cents to add to that.
So Anna, it sounds like this communications approach or PR campaign is actually, there's some urgency here in order to get these services into communities where there might otherwise be pushback. And I'm hearing a lot of enthusiasm for putting together campaigns that can address, both educate community members and start addressing that stigma. I just want to jump in and add, so as I mentioned, Kashi is not able to make the meeting today. She has a conflict, but she did send some thoughts ahead of time. And one of the things that she mentioned was that the CRIS should articulate a plan to address the lack of awareness of alternatives to 911. Maybe this could include some public health style education regarding what is unpleasant behavior called 988 versus truly unsafe behavior called 911. So while that's a little bit different from what Anna was just talking about, I think it falls into the category of more education for many of us who don't really understand behavioral health and how it manifests and what are the true safety risks versus more like things that we're just unfamiliar with or uncomfortable with. So thank you for raising that, Anna. Got a couple of messages here in the chat that I want to make sure I capture. Let's see. Something I think that is missing adjacent to stigma but different are the harms that can happen to individuals when mainstream models don't work for them, when providers are harmful accidentally or intentionally. There is so much fear, so much exhaustion from people trying to access help, but instead getting harmed further. I don't know how, but there has to be a way to try to leverage something here. That was from Puck. Thank you, Puck. And then Bipasha is responding to Dylan's thought. I hear and agree with Dylan. We have to do this centralized and at a very high standard, or else it's just one more thing. That database needs to have the end user provide usability inputs, not just professionals. Needless to say, after it is solid, it also has to be advertised and used. Thanks, Bipasha. Kim.
Hi, I wanted to just add on to the conversation that Anna raised so well about stigma and facilities that are coming online. I think public education is really important, but I think we're always going to have to just anticipate some levels of NIMBYism and of real strong pushback in localities. And I think the state has to sort of has tools, both legally and otherwise, and those are politically difficult to use, obviously, but is going to have to be prepared to use them. Because if we do want to build 10 new crisis facilities, if we do want to build intensive behavioral health facilities for discharge, if we do want these facilities online, like they have to be built someplace, and there's going to have to be some really difficult discussions with those local communities. I mean, they're being built all over. But I think getting out ahead of that is going to be important, and that the state is going to have a lot of responsibility to do that and to be very transparent and unified and forceful about it.
So Kim, I'm hearing you say, okay, let's address the stigma, but also let's be prepared to understand all the tools at our disposal and use them so that we're not delayed in getting these facilities online. Is that
right?
Is that
because we've been seeing that. I know lots of people on this call are experiencing that firsthand. There's been delays in a lot of the facilities we've been trying to open over the past several years.
Yeah, no, I hadn't thought about that. So Anna raising that and you echoing, I think is really important. So thank you. Representative Orwell.
Thank you. And that was a really important comment. I wanted to jump in on that. Two things I would say is I actually talked to a mom last month whose son was really having trouble and was trying to find an alternative to the emergency department and jail. And she lived 2 blocks from the Parkland RI facility. And she's like, that facility, that's the one our community fought against. And it was like an aha moment for her, because that was actually the best location for her son. And I kind of see this as an opportunity. Maybe there's something we could do to educate on 988. A lot of our cities are excited about this, these facilities. We're still trying to figure out how to pay for operating, but maybe there's kind of a joint partnership, with people with lived experience and our local folks and state folks really doing some forums to really, again, get people realizing how important these services are.
Really appreciate you raising that, Representative Orwell, especially in light of Dylan's earlier comment about leveraging the networks that we already have, and Representative Dent talking about his own family's experiences. If I'm hearing you correctly, it's it's probably reasonable to expect that a lot of people in the communities where these facilities are going to be located have loved ones, or they themselves have lived experience. And when we can start to draw some connections for people between their own personal experiences or their family's experiences and what these facilities are going to provide for the system, maybe we can start to break down some of those NIMBY barriers. Did I hear that right? Okay.
And I just add that our cities are our partners. And so it's really important that before things are cited or early on, that we bring them in as partners because they can help.
That is an excellent point. So maybe getting, as Kim said, getting out ahead of this. Okay, they have a comment in the chat and then I'll take Dylan. So stigma lives with, this is from Bipasha, stigma lives within all of us, within families and communities. Everyone everywhere can play a role in helping address behavioral health issues because it always starts within a family and a community before it might become systemic. And I think that was very prescient for what we were just talking about. So Dylan and then Dr. Snowden. Dylan?
Yeah, and along the lines of leveraging our networks and just talking about the resource that's now available, but also just like walking the walk. And when we see stuff, I think it's really common where people just walk on by when stuff is happening in front of them, that we can also just show if someone, it maybe seems like someone's having a hard time, we can check in with that person and use that as a moment where I'm like, can I call someone for you, or can I help you get there? And it does not require someone to be a medical professional or a mental health professional to get to that point. And in fact, this past weekend, I had an experience where someone was having a hard time. I did the call, and then people were like, "Oh, are you part of the mobile outreach team?" I'm like, "No, I'm just a person." And they're like, "Oh, I get it." But I think it just highlights the fact that people don't know what to do, and I think there can just be more education about how to respond when it looks like someone might need some help.
So educating through modeling the behavior we want to see, is that right?
Yeah, and also, things like a mental health first aid, just getting more of that stuff out there for the everyday person, the lay person.
Wonderful. Dr. Snowden.
Thanks, Jamie. I would comment about the concerns about Not in My Backyard. The experience the university has had with the new teaching hospital has been funded. It's actually been very good. And so while I think it's an issue, I think with the right approach with the community, it can be overcome, because fortunately I can say that's really the least of our concerns about the opening of the new teaching hospital. The neighborhood in which it's located, I think, is fully supportive of it. I wanted to sort of change the topic a little bit from stigma, not because I don't believe that stigma is an issue, but I'm trying to be true to the voices that we've heard of people who've had bad experiences having overcome the stigma and tried to use the system. And so while I think education and information is great, we've heard from a lot of people that I think know a lot about behavioral health and the issues and are still encountering problems. And so as I try to figure out from these root cause analysis areas, what would help them, I'm not sure more education would really help them per se. I think what they really need is for us to really hold our system more accountable. And what I mean by that is, one of the big differences between calling 911 and calling 988, if you were to get a response in the 988 system, is how quick would it be? And I think a lot of people know what behavioral health issues are. They know that there are other places they can refer people, but there's no place that they can refer that will get the speed of response of if you call 911. And so somehow I think we've got to just be honest about that. And so to say we have to expect more of our system for the people that are choosing to use it. They've made the leap to using it, but what can they really expect to get from it? The other comment I would make is, as I looked at some of the issues that really boil down to rural versus more urban or metropolitan issues, is I wonder if the strength that we have as a state in terms of regional variations, when overused, has become our weakness. And that because we are accustomed to letting regions do things the way they think is best, we've now left rural parts of the state to their own devices and say, well, you guys just figure this out as best you can. We're going to let you do it, rather than having a different approach, which says everybody really does have to have access to the same thing. And it's not going to be enough for a region to simply decide they can't do such and such. I think the approach that gets us out of that has been promoted by SAMHSA and the crisis jams, is to really have population metrics and say, for a given population area, this is what you should expect to see in terms of mobile crisis response, crisis stabilization, and access to psychiatric hospitals. And if you don't have that, you should really recognize that you have really not provided the resources that are necessary for that community, even if it's a rural area.
Thanks, Mark. So what I'm hearing is two pieces. First of all, that we need to really look at the performance of 988 as compares to 911 and make sure that people that make that choice to call 988 are getting the same level of standard of care in terms of response time that they would at 9, or at least close to it, so that they wouldn't forego the other benefits of calling 988 so that they can get faster response. And then I am also hearing you talk about really what we're going to be tackling in 2024 primarily, which is our metrics, and how do we set metrics to make sure that rural areas, that there's equity in services that we're providing in rural areas. Our root cause analysis called out some inequities in terms of people accessing crisis stabilization services in rural areas. And I'm hearing you say we need to make sure that there are metrics so that we can tell when those rural areas aren't getting the level of service that the more urban areas are, and then focus on investing and improving there. Did I get that? Thanks, Dr. Snowden. All right, let's take Michelle and Bipasha, and then I want to share some of the other root causes and ideas that Kashi sent in. Michelle?
Well, thanks. I appreciate this discussion. I'm going to kind of switch gears a little bit too, and I know this was about root cause around crisis stabilization, but being in public health prevention, I can't help but notice the first square on the box was about lack of services from helping people not reach crisis in the first place. And I think there'll be some level of crisis no matter what. And that is something that I think we're building and working to address, including this discussion. But I do think our recommendations long-term should look about what upstream prevention programs and how do we want to describe our prevention system in the state, which I don't think is consistent. And I don't think we have a core set of prevention services and community asset building programs across the state that we could describe in any comprehensive way. And that might be something we want to take advantage of in this in these recommendations to consider.
Okay, so I'm hearing a concrete recommendation from Michelle that we address that first box by really starting to talk about what kind of upstream support we want to see to prevent people from requiring crisis in the first place. All right, Bipasha.
So this is kind of addressing what both Dylan and Mark said, and I'm trying to practice the yes and model in my own life. So I'm trying to do that here. I work on the crisis line. I've had people call and say, oh, so-and-so's laying on the street. They are talking to the air, or they're gesticulating and behaving a little aggressive. Sometimes even just laying there naked. What can I do? So I think that education piece will really help, because I feel I'm hearing that more. I've been doing this for 25 years. In the past, I wouldn't hear, people were more wary. But I think with slightly more awareness of behavioral health, people are trying to ask that question. However, this is the yes and part, which is that not everyone is comfortable going up to a person like that. They're wary, they're scared, which is why I'm hoping the mobile crisis response would be helpful in that case. So we can say, hey, where is this person? You know, I've sometimes like what street, what junction, let's engage through 988 mobile crisis and send the team out. Now, there's no guarantee that the person will be there, but it's well worth trying to see if the mobile crisis team can intervene. So I think the education will help the public, but can't expect the public to respond to, things that might be uncomfortable to them. Thank you.
Thanks, Pasha. All right, I'm going to turn to Kashi had some other root causes that she tackled. I'm going to turn to those and see if we can see some of your ideas here. So the first one she circled is the one on the first page. Limited resources impact staffing and services available to address someone's needs. And I think this is particularly related to crisis receiving centers having restrictive eligibility criteria. She said this seems within CRIS's purview to address, especially regarding funding and training standards. And she had some ideas. She mentioned funding needed for behavioral health crisis systems, especially in rural communities. So this is actually really fitting with what Dr. Snowden was just talking about. Ideally, this would be funding enabling payer blind crisis services. So not just for Medicaid clients or not just for commercially insured clients. And let's see, I think that was her idea there. And then some of her other ideas echoed some of the ideas we were already talking about regarding messaging campaigns or awareness to catalyze behavior change. So we've talked a lot about addressing stigma, about public relations and communications and education. Do folks have other root causes here that they want to talk about and ideas for tackling that? Representative Dent.
Well, thank you. Jamie, I'm going to leave my camera off. I'm not in the best place in the world here, so it seems to work better with it off.
Sure, no problem.
And I really appreciate this conversation. I've heard some really some good thoughts and ideas here. So I think sometimes we don't think about the folks that are struggling with mental illness. And I've had to adjust my thinking to think about that. But a friend of mine told me one time, we were talking about my son and some challenges he was going through at that time. And he says, Tom, he says, when he wakes up every morning, he doesn't know what he's going to be. And you and I have a pretty good idea who we are. But every morning, it's a different challenge for him. And he says, sometimes, he says, I think, and he was giving me this lecture, okay? Sometimes we have to let's see what this day looks like for him before we get too engaged about helping other folks, right? And so, that's been really, really good advice for me so, I have a son who's mentally ill. Well, then he attracts other people who are mentally ill. So most of his friends have the same challenges, right? So it's not like I'm just hanging out with one of them, right? So, and I've learned to just kind of get a feeling for where they're at today and what it's going. But I've also learned the value of just giving them a hug and how I can transform what could be a bad day for them into a good day. And we all know, and maybe I'm going down the weeds a little bit here, and I live in a rural area where there's a definite lack of services, but we all know there's a lack of services. We all know we don't have enough mental health providers. We all know these things, right? And it's going to take years to fill this pipeline. And in the meantime, everything we can do just as human beings, as people who care about other people, that we can do to give them, to lift them up, to help them, to give them a better day, I think is a very positive thing to do. I spend days sometimes with some of these kids. They really struggle, and then all of a sudden you'll spend a week with them and it's almost like they're normal. But we've given them so much, some positive in their life. I think that's one of the most important things we can do. Anyway, you can see that I have some passion for these kids and helping them. And kids, and they're 30 years old now, they're not really kids anymore. But anything we can do to reach out and lift these people up, but also accept the fact that, from their side, I have no idea what it looks like from his side. Sometimes it's like, I should sit down and I think about, okay, so what is he feeling today and what is he faced with? And then how can I do a better job? And I think that's some of the root cause. We're trying to fix them, and maybe we just should accept them and help them move through life.
Again, Representative Dent, thank you so much for sharing your personal and your family experiences. I think, like our personal stories at the beginning of the meeting, they're particularly meaningful for all of us. And I appreciate you sharing your experiences about how you meet your son where he is that day. And you're thinking about how there's things that we can do as humans to one another, even as we're waiting and working so hard to bring these new services online. I was also just thinking about what Dylan was saying earlier about his experience last week. And see in my in the chat here from Bipasha, she mentioned that in our lived experience subcommittee, Kristen's mentioned the mental health first aid that was mentioned earlier. And that maybe when kids are in school, we have everyone do mental health first aid. So folks learning about what we can do as individuals to support each other and provide support. Obviously, I think there's probably gonna be some education about what is most helpful and safe for the recipient of that. But I appreciate all the ideas here for what we can all do as humans, while at the same time working so hard to get these services in place, especially in rural communities. I do also want to mention a comment here from Betsy. She mentioned she's taking a look at the 911 region RCA WISE, the ones in our root cause analysis. So the ones related to 911. And she said a lot of the content from the first responder collaboration work group will be applicable to those WISE. So maybe we can do a little dive into that and offer up some of the outcomes from that might address some of the issues we have in the root cause analysis. Huck.
Hi, can you hear me?
Yes, you sound great.
So I want to echo Michelle's comment on prevention. In chatting with the lived experience work group, we seem to constantly come back to the way that we have dismantled our social safety net over the past while. And I know that hopelessness is a huge part of so many mental health crises. And I know as a person with lived experience with a degree in trying to support people in navigating these kinds of systems, like I need a lot of help that I don't know how to access right now. And that personally makes me feel really hopeless. And being on this committee and further not knowing how to access it still, terrifying. And so it's not specifically within the purview of the CRIS, but as much as making strong recommendations for prevention services, I think that encouraging the system to invest more in basic social safety net kinds of things, which we are doing with the 23-hour centers, but like houselessness is a crisis and drug addiction is a crisis and not being able to access food stamps is a crisis. And just all of these, if we're doing a root cause analysis, like these are also a lot of the root causes.
Yeah, I hear you, Puck, that probably that first box in our root cause analysis could be its own root cause analysis, where we could look at all of the things that contribute to someone having a mental health crisis, like you said, like houselessness, food insecurity, those stressors. So thank you for that. And I appreciate your echoing what Michelle said about making sure that whatever we come up with includes some strong recommendations about prevention. I want to go back to some of the pieces that Kashi called out in her email. She mentions the root cause of we have not established collaboration, partnership, and trust between 911 and 988 systems to better facilitate coordination and handoff across systems. Feels like a significant role the CRIS Committee was formed to advise on. This is our work. It is critical that we end with systems that can communicate effectively in order to equitably and responsibly ensure a caller in distress receives appropriate responses and care. So I think what she's saying here is, as we're looking at where we address systems gaps, this would be a really, really important place to start. And one of her ideas that she'd like to see more investigation on is how do other states reduce issues between 911 and 988, or more broadly between first responders and behavioral health systems. So maybe we don't need to invent this. Maybe we can borrow from what other states have successfully done. Representative Orwell and then Senator Dingra.
Yeah, I just want to respond to that. I was at South Sound 911 and Levi was there, and they just started their partnership to do the co-location. I know DOH will be helping to facilitate that in several of the areas. And I do think that is one way to develop the protocols and to really figure out how to work together. And so, certainly DOH or Levi can give more details, but I do think it's important. I also, and this is where I feel like this group can weigh in, is we want a great partnership between 988 and 911, but we want 988 to be its own entity. There's a lot of people that won't call 911, and how do we have partnerships, but people, see 988, the clinical response and the non-police response. So I think there's kind of a deeper conversation that this group can have.
Thanks, Representative Orwell, and thanks for sharing those insights from the inside. Senator Dingra.
So, obviously, all of us here are really committed to the 988 work. And just today, I had gotten a text from a mom, and she texted me saying that she was listening to the story about gender affirming care, and in that story, they were talking about calling the 988 number for help. And she wanted to text me to tell me that she thinks that it's dangerous to call 988 because it'll criminalize her trans kids. And I texted her and I said, that's the whole point of 988, is that we're trying to have an alternative to law enforcement. And she said, they're so deeply connected to 911 that my trans child does not feel safe calling 988. And so I'm going back and forth with her on, trying to make her feel like people should not feel like they're going to be criminalized when they're calling 988. But I can't really, I tell her that that's what we're trying to do. But the reality is there are many situations where we do need law enforcement to show up because it's not safe for non-law enforcement to show up in that scenario. And I do love that we're doing 911, 988 co-location, because I know it's critical to make sure we have the right response for the right situation. And this goes back to something we were talking about earlier. I think Bipasha may have said that, is how are we messaging and talking about the system, and how are people of color, marginalized communities, LGBTQIA communities receiving this information is very important. Understanding that the reality is that that collaboration between 911 and 988 has to be there. And anyway, I just wanted to share that given the conversation we were having and continue to have. And I would highly like to echo one of the ideas that someone had mentioned, maybe it was Dylan, about having a subcommittee for maybe marginalized groups, that we do need a way to have this conversation. Because this system is only successful when you have buy-in from individuals. And I know we've struggled in this group, as has society in general, about the 911, 988, but the reality of the situation really is that we are going to need to partner with our law enforcement officers, because you do need them to show up, but you need them to show up in a way that is helpful. And I think a month or so ago, I had shared with this group on how my daughter's friend, their family had to call 911, and I showed up to the scene as well. And, I saw law enforcement do what they do. And, I've been thinking through, yes, that was traumatic for the individual and the family, but I can't think of what else could have happened given the threats that she was making. Because unfortunately, when there are threats to harm others and to harm yourself, I am not sure what that system looks like without without some law enforcement there. So anyway, I know I rambled a little on towards the end, but I think it is important to try to put those in words where people still feel like they're not going to be criminalized when they call 988, even though there is a collaboration between 911 and 988. Because we're building that bridge that's going to lead people to get help and not necessarily go into the criminal justice system.
Senator Gingras, thank you so much for sharing that other side of the concern or the nuance around collaboration between 911 and 988. And I saw Huck nodding their head vigorously, and they also sent a chat saying that they've said this before. Most of my community don't feel safe calling crisis lines because we can't confirm to them that we will not involve police. So this is a reality and a tension that I'm hearing that we do need to address. And it sounds like Claudia's idea of a subcommittee, Claudia specifically mentioned people of color. And I think Senator Gingras, you expanded that to also include other groups that feel threatened or marginalized or vulnerable, who can maybe not even just focus on systems and message, or not just focus on messaging and communications, but also user experience and system side of things. So thank you for that. I want to do a quick time check here. It's 3:46. I do have one person signed up to make public comment. So I want to wrap up this discussion in about 5 minutes so I can do action items and next steps and take the one public comment. And veterans too, thank you, Puck. There are two hands, one from Chief Harding and one from Representative Dunt. And then I think we'll try to wrap things up and talk about next steps. So Chief Harding.
I was just going to highlight another piece of information that we need to start putting out, and that is, current training for law enforcement and some of the topics that new officers are trained in. Trauma 101 for law enforcement, tools and skills for working with trauma, history of race and policing. I mean, these are courses now that are taught through the Criminal Justice Training Commission. And that information I sent to Nicola, I think we could put that out maybe to the CRIS Committee. It's fairly detailed from Jarrell Wills, Deputy Director of CJTC. And it lists the course objectives. I think it gives a lot of encouragement that can help to overcome some stigma that, law enforcement aren't trained. We have a long way to go, but new officers are coming out with a greater understanding than we've ever had of what behavioral health looks like and how it's, different than what violence looks like. And that they have a sophistication that did not used to be there. So I think maybe adding some of that information may help people feel a little more comfortable as well. Because there will be times that it's a 911 response. I don't know that that's avoidable 100%. So there's making headway there.
Thanks for that, Chief Harding. Nicola's on vacation right now, but when she gets back, we can get that information and pass it along. So thank you so much for that. I see Representative Dent, and then we have a couple more comments in the chat, and then we'll wrap it up. Representative Dent.
Thank you, Jamie. So, I just want to agree or want to echo Senator Gingras' comments about, we can't criminalize everything that happens. We can't criminalize every call that goes into 988 or 911. Because as long as we continue to do that, we're going to limit our calls, in my opinion. And we're going to have people that aren't reaching out that we'd like to reach out. I like Chief Harding's comments there around law enforcement. And I really like the idea. And I think it was Dylan maybe that brought this up, around having a subgroup to take a look at some of these issues. So anyway, it's been an incredible discussion. Thank you everyone for your participation. I really appreciate it.
Well, thanks for doing double duty today, Representative Dent, being in two places at once. It was really good to hear your insights. A couple of comments in the chat. The lack of trust, this is from Bipasha, the lack of trust was created by the system, not by communities. So the system has to take the responsibility to earn the trust. By system, I don't just mean first responders, but many, many other systems that make some wealthy at the cost of others, leaving their work and effort unrecognized. that is a deeply traumatic experience. Okay. Any other thoughts from CRIS committee members before we wrap up this discussion for today? Yeah, yes, Puck.
Yeah, so every time I speak to community that fears law enforcement, I'm doing it in these conversations about how do we increase community participation in the CRIS process and in the 988 system. And every time I do that, I hear from someone about what law enforcement is doing right now to try to be better. And I'm stoked. That's awesome. Let's have law enforcement be better. That's great. Thank you, Captain Harding. But also, we have communities that are afraid of asking for help because of this history. And so the reason I bring that up right now is because we're still trying to make recommendations and we're still trying to make policies to try to keep that from happening more in the future. And so even if agency by agency, things are getting better, which I desperately hope, we still need to be trying to make recommendations to say, here is what we want. This is the bare minimum. Because I do desperately hope that those new officers are trained better and are getting better and are going to be better able to support people. But we're also dealing with the fallout of where we're at now. And so as we're talking about root causes, the current training is not the root causes. Society is the root cause primarily. But we need to acknowledge the effect that those causes have had as we are planning to move forward. So that's where I come from when I repeatedly talk about these concerns. It's not saying, hey, you're doing things wrong right now. It's saying we need to address what's going on and these perceptions that exist.
Thank you so much for sharing that. And I see a lot of nodding heads and some echoes in the chats that this is as much about the repercussions of what's been done to date and how that's affecting people who need help and are afraid to access it, as well as what we do for folks in the future. And I hear from Bipasha here, as you were talking, she was reflecting and writing, please listen to their effect. I hear it all the time. This is a real thing. Please listen. This brings many communities to tears because they are really afraid of not being seen, let alone being treated as the full humans that they are. So, and I can see that's really affecting you, Puck, too, right in this moment. And I'm grateful to you for sharing that with us. See, it's affecting a lot of CRIS members here.
I feel like I'm some kind of rabble rouser here, and all I'm doing, the only reason I'm here is because all of my friends are dying. That's why I want to do this work.
I don't want to contradict you, Puck, but I though just looking at everyone's faces here, I don't think I don't want to speak for others, but I don't think we're seeing rabble rouser. I think we're seeing someone who's sharing their heartfelt feelings and what they're experiencing in their community. So thank you. And I'm seeing lots of chats popping up from people who are sending love and appreciation and support to you. So thank you for making yourself vulnerable there. And thank you to everyone in this community for supporting you and doing that. I think the message is really, really important. I'm going to close this conversation out now, but I want to say I believe this is not the end of this at all, but an ongoing conversation. I also want to acknowledge that Puck and others and Chief Harding are all working together in collaboration, as Michael Anderson-Nathan mentioned earlier. And so I think we're going to be doing a deeper dive into, as a group, into some of the things that we were just talking about and what Puck was sharing about. Not just the future, but what do we do in this moment? But I do want to thank everyone on the CRIS for doing the thoughtful deliberation today about these root causes and how we might start to address them. Very quickly, I'm going to run through next action items and next steps, and then I'd like to call on the person who's signed up to make public comment. So what I have for action items is Megan is going to check on finding an answer to Bipasha's question about affinity groups inclusion, the affinity 988 affinity groups inclusion of people of color. I'm sorry, people with lived experience, excuse me. I need to be able to write so I can read my own handwriting. Then everyone, call to action for you to provide feedback to HCA on any ideas you have for filling the CRIS vacancies. Brittany or Chloe, did I miss any action items?
Not from my perspective, Jamie, thank you.
Okay. All right, great. So we have one person signed up to make public comment. Brittany, can you remind me of who signed up?
It's Sriram Rajagopalan. I'm so sorry if I butchered that.
Okay, so Sriram, when you're ready, if you want to turn on your video camera, I'm going to put the clock up on the screen, and you may go ahead and start when you're ready.
Hi, can you hear me?
Yes.
Okay, great. Hi, my name is Sriram. I am a member of the CRIS Tech Subcommittee, but also a person with lived experience in mental health. I go by pronouns he, him. I first wanted to just acknowledge the moving statement that Puck made, saying, Puck, hear you, this is a problem. There is a huge lot of damage the system has done, and there is the level of trust in the system is really, really it's at a very low level, and we need to rebuild trust. And I think one of the things that I wanted to bring up in that context of building trust is that to build trust, the system needs to actually be seen as helping people and helping enough people. And at the last lived experience subcommittee meeting, we heard some horror stories about what happens after a place to go, they're discharged and they're out on the streets homeless. So it really feels like a place to go is that really a place where they can recover also? Is there a place where they are at a place where they can actually get to a safe space and, actually get through the trauma that they are dealing with, get to a better place? And I think that's one of the things in the system is we seem to have a revolving door, or once you're in the system, it's really hard to get out of the system. You keep coming back in, and you can say this is about prevention, which it is part of it, but it also feels like the discharge part of when you're leaving the crisis system, what next feels like it needs to be a very important part of what the CRIS should be looking at and having some metrics, because that goes into the accountability that Dr. Snowden was talking about, because the accountability is the person is actually able to recover and have a productive life. So I just wanted to add that to it. Thank you.
Thank you so much, Sriram. And I don't believe we have anyone else signed up for a chat, for a public comment. So with that, I think that concludes our June CRIS Committee meeting. Again, CRIS Committee members, thank you so much for coming, for being present, for sharing your ideas and your personal experiences. And a big shout out to our community members and guests who give so much time to participate in these meetings, and most especially to everyone with lived experience who comes here, who shares your stories, who, despite the challenges and obstacles we face, continues to do this hard work. It is really important, and we're very grateful to you. And with that, I wish you all good health. Happy beginning of summer starting tomorrow, and we will see you in July. Thank you, everyone.